These are my disclosures, which are not relevant. So as you're aware that there are two components to the ACLs, and opposed to just looking at it as one band on MR, you really want to look for both the anteromedial as well as the posterolateral band, because they have different important functions for normal knee stability. And indeed, this is important when looking for partial thickness tears. So everyone is familiar with looking at this. This is just a blown out ACL. It's a very easy MR diagnosis, and arguably, you don't need me to tell you that the ACL is torn. When we have more subtle injuries, use the fat suppression, the bone marrow edema pattern, to predict the mechanism of injury. I have a matching bone marrow edema pattern at the anteromedial margin of the knee. That indicates a hyperextension injury. So I'm looking for injury to the ACL. Indeed, the posterolateral band is torn. And because at the medial margin, there has to be a varus injury. So then we look at the posterolateral corner and see, in fact, that there's a partial tear of the fibular collateral ligament. So he underwent a partial ACL reconstruction centered on the posterolateral band. If you see injury on the MR, always check for posterolateral rotation at EUA and be prepared potentially to have to do a concomitant posterolateral corner. Meniscal tears associated with ACL, this is the one you'll love to see. Vascular zone, peripheral longitudinal, very nicely and easily repaired. We also look for that injury at the lateral meniscus root attachment. As the tibia is rotating and translating, we can see injury at the attachment of the meniscal femoral ligament. Of course, vesicle disruption that may lead to delayed instability. But look also at the root attachment of the posterior horn, where that tibia rotates. We often see a large radial split or displaced flap. These may be subtle. You may look at this and say, well, Hollis, is just a transchondral fracture, bone marrow edema pattern. But look very subtly how it's blunted the posterior margin of that anterior horn, and that's a discrete little radial tear seen there. So we know that we talk about the so-called bone bruise, and we know that cartilage resists compression but not shear. So compression over the condyle, but shear over the plateau, in this case producing a full thickness cartilage defect with a free fragment in the meniscal capsular junction. So when does cartilage start to go bad? Really 5 to 7 years is where we start to see progressive osteoarthritis in the setting of an ACL tear isolated without a concomitant posterolateral corner or meniscal lesion. So isolated ACL, 5 to 7 years. So we follow them over time. We can see how that transchondral fracture remodels. But what's interesting is what's happened to the plateau in an area that was not perceived by that quote unquote bone groove. We do a T2 map for looking at collagen, we can see that there's depletion of matrix. So indeed, there is a global effect on cartilage health in the setting of an ACL tear. So back one. So 100% of ACLs result in chondral damage that we can see on MR. These are not just ho-hum cartilage injuries that are not clinically relevant. They are at risk for progressive damage as a function of time. When we look at ACL reconstructed versus non-surgical, in our cohort, we did see a chondroprotective effect in those that underwent ACL reconstruction, and these resulted in a substantial, statistically significant differences in patient-reported outcome scores, including the subjective IKDC and the activity rating. Don't dismiss signal in kids. This is a 6-year-old with a full thickness ACL tear. He's got a lot of signal in his meniscus, treated conservatively. And what we see over time is that he's got a horizontally oriented remodeled ligament that's incompetent with a very degenerative meniscus now forming a meniscal cyst. Ganglia, 1 year later, you can see how these become exophytic, and these are arthroscopically available for debridement in the setting of impeded full flexion in the knee. They usually do not indicate ACL insufficiency, however. We can see how those remodel. Now, acute skiing injury, clear ACL, transchondral fracture, so ACL, no biggie, transchondral fracture, basic stuff, MCL. Just because you see injury of the MCL to femur, don't stop looking. Make your eye go all the way to the tibia. This is a tibial footprint avulsion. Notice how the low signal intensity cortex is gone. This is a bad valgus injury, so that's a lot of stiffness. And when you're thinking about management, particularly in a 58-year-old, this patient was treated conservatively and worked through the stiffness of the MCL. Let's talk about posterolateral corner. I'm going to take you through normal. Here's the popliteus. Popliteus starting to come up, biceps femoris footprint. I'm following the popliteofibular ligament seen here. I'm still following the popliteus. I'm going to go through multiple coronal images. Now I'm starting to pick up my fibular collateral ligament. And I have to go, depending on your slice thickness and your slice gap, 4 to 5 images before I get all the way to the popliteus. To clear it, you have to go all the way forward on your coronal images. So in the setting of a posterolateral corner, biceps femoris off. Here we can see that the popliteofibular ligament is torn. We follow through, we can go all the way. There's no popliteus, no low signal tendon, okay? So make sure you walk all the way forward to exclude a major posterolateral corner. In this setting, this is a multiple ligament knee with both ACL and PCL. How about after ACL reconstruction? This looks great, right? Low signal intensity graft. It's absolutely perfect. No, it's not. It's vertically oriented. This is a wide pivot in this knee. So it's not just about signal, it's also about orientation. So clinically unstable knee. So we can look at KT side to side differences. These are two different patients, 6 millimeters side to side, 4 millimeters side to side. What happens to the graft? The graft is all gray, it kind of looks kind of stretched out. That indicates there's increased mobility of water. We can take that a little further. This is a study in a rabbit where we controlled strain through an X fix. With me staring at the grafts, couldn't see any difference between loaded or unloaded grafts. But when we did relaxometry, this is T2 star relaxometry, looking at collagen orientation. This is becoming commercially available, and we can port this to our patients now and get indirect, non-invasive measurements of graft strain. 2 patients, restricted pain and motion, not a big surprise. Here we have this large exophytic cyclops lesion up against this ACL. In this patient, you would argue anterior placement of the femoral tunnel. It's not always a cyclops. In this case, it was displaced plastic interference screw. So you always want to think outside the box about fixation. This is a patient with persistent, he's undergone ACL reconstruction 10 months later. Let's evaluate it. Graft looks bright, looks like it's under some degree of stretch. Always in the setting of patients that you think of clinically failed ACL reconstruction, always look for delayed posteromedial or overlooked posterolateral instability. So let's walk through the posterolateral corner here. Biceps femoris doesn't look good. Here's my popliteus. I follow it up and then it stops there, right there at the lateral meniscus. I walked through and I couldn't find it at the femur. Fibular collateral ligament gone. This was doomed to fail. This is a graft that clearly had too much strain in the setting of overlooked posterolateral rotatory instability. You treat the patient, you don't treat the MR. This is double bundle quad PCL reconstruction, 4-strand hamstring. I would argue the graft is a little bit bright. He had posterior draw B, but the posterolateral corner was symmetric. Let's look at the posterolateral corner, shall we? Well, clearly the popliteus arm of the posterolateral corner is off, but there is sufficient tissue here to prevent varus resistance so that the side-to-side difference was not remarkable. Fixation, let's just finish a little bit with that. Synovitis, just remember biabsorbable in a suitable host. Biabsorbable implants can lead this kind of exophytic intermediate signal intensity synovitis. The patient may appear to have a synovitis, doesn't mean they're necessarily infected. Your MR radiologist should be able to tell the difference. Just seeing this very intermediate, doesn't look like infection type of response. So synovitis may affect the mode of fixation or infection. We always want to think about quantitative techniques as we move forward to give you indirect insights into tissue strain. And you always correlate the MR findings with the clinical function of the graft and the patient's symptoms. And I thank you for your kind attention.